Hello, my name is Thomas Hurley, and today I will be taking you through a client assessment of my gym partner, Alyssa Pisano. There are a few goals that I have for the assessments, those being to figure out and identify the compensations in each of the views and movements, and I will then list what is overactive and what is underactive in said compensations. So to start off, we have the static postural assessment. In this test, I will be assessing the kinetic chain, and the observations are the checkpoints that follow: the head and cervical spine, shoulders, the lumbo-pelvic hip complex, the knees, and finally the feet and ankles. You will see I have three different views, those being anterior, lateral, and posterior. In the anterior view, we want to see the following: the feet to not be internally or externally rotated, the ankles to be parallel, the knees in line with the feet but primarily the toes with no valgus or varus, the pelvis to be level with the horizon, shoulders to be level with each other and not elevated nor rounded. Finally, the head should be in a neutral position. Now, firstly, I noticed in my client that she had an inverted left foot. For the muscles that could be underactive, they are the peroneus longus, peroneus brevis, and peroneus tretus, the glute medius and maximus, and the intrinsic foot muscles. The muscles that could be overactive are the anterior tib, the posterior tib, the soleus, the gastrocnemius, the flexor digitorum longus, as well as the flexor hallucis longus. I also noticed that the left knee was externally rotated with a slight knee valgus, as noticeable here. I'd expect the following muscles to be overactive: the bicep femoris, the TFL, the adductor complex, the lateral gastroc, the soleus, the posterior tibialis. I'd also expect the following to be underactive: the glute med, the glute max, the anterior tib, the medial gastrocnemius, as well as the six deep external rotators. Lastly, you will notice here that the left shoulder is elevated. Here I would expect the following muscles to be overactive: the upper trapezius muscles, the levitator scap, the sternocleidomastoid, the pectoralis major, as well as the pectoralis minor. And the following to be underactive, and those would be the lower trapezius, the middle traps, the serratus anterior, and the deep cervical flexors, which I also showed here with this line to show how much higher the left shoulder is elevated. Next up, we have the lateral view. In this view, I'm looking for the foot and ankle to be neutral and for the leg to be at a right angle with the heel. It needs to be neutral and not flexed or hyperextended. The pelvis to be neutral and not anteriorly rotated. The shoulders to be in line with the ears, and the head to be in a neutral position and not jutting forwards. Here, I noticed increased lumbar lordosis, which will be shown here in these two arrows. And this would mean that the adductor complex, latissimus dorsi, the psoas, the rectus femoris, extensor complex of the spine, and the tensor fasciae latae all to be overactive, as well as the external obliques, glute maximus, hamstrings, and rectus abdominis to be underactive. This is also another angle for the inverted left foot, as we spoke about earlier. And as you can see by the top arrow, the shoulders are rounded on the left side as well as elevated. This would mean that the upper trapezius muscles, the levitator scap, the sternocleidomastoid, the pectoralis major, pectoralis minor are all overactive. as well as the lower trapezius, middle trapezius, serratus anterior, and deep cervical flexors. Now those are all for the elevation. Now for the rounded shoulders, I would also expect the anterior deltoid and subscapula to be overactive, and the rotator cuff muscles and rhomboids to be underactive on top of the other muscles listed prior. Now in the posterior view, you can see again how the left foot, right here, is inverted, and you can see that the knee valgus, as before mentioned, in the anterior view. You can also see that the left and right knee are valgus as mentioned prior. You can also see up at the top, the shoulders are again not even. Now we have the overhead squat assessment. This assessment is a transitional assessment. This means that the movement is done without a change in any support. This test assesses core strength, balance, flexibility, and neuromuscular control. Again, this was done in an anterior, lateral, and posterior view. I am looking to see if the feet change in any way, such as flattening or turning out. A slight caveat would be that my client did not want to remove her shoes for her own personal reasons. In her knees, I am looking for valgus and varus. Valgus would mean that her knees internally rotate, and varus would mean that they externally rotate or push out. Now in the anterior view, my client's feet are slightly everted. This could relate to an overactive bicep femoris, lateral gastrocnemius, and soleus. Now the underactive muscles here would be the anterior tibialis, medial gastrocnemius, as well as the glute maximus and minimus. However, this could be her compensating for the other leg, as we noted earlier in the static assessments, with multiple imbalances. Now when I begin the video, you will see that there is a weight shift to the right leg, as noted with the arrow as well as the line. This could mean that there is an overactive adductor complex and tensor fasciae latae. The underactive could be the core stabilizers and gluteus medius, while the left side expected that the bicep femoris, gastrocnemius, and piriformis are overactive, and the adductor complex is underactive. It is also notable in this view that she drops her chest, which will be touched in the next view. In the lateral view, we are looking for compensations in the lumbopelvic hip complex and the shoulder. Here we are looking for arching in the lower back and a forward lean. The compensations I noticed are as follows. My client dumps her glutes in both views, as seen here and here, with some arrows pointing to those. For the dumping, the overactive muscles are more than likely the soleus, gastrocnemius, hip adductors, TFL, latissimus dorsi, and rectus femoris. The underactive muscles would be the gluteus maximus and medius, core stabilizers, anterior tibialis, and middle and lower traps. You will also see a weight shift to the right leg again, as in the before mentioned slides. Finally, she drops her chest, which would be excessive forward trunk lean, as seen here by these upcoming arrows. Dropping a chest and arms there, as well as dropping the chest and arms here. The overactive muscles are more than likely the adductor complex, external obliques, gastrocnemius, the psoas, the rectus abdominis, the rectus femoris, soleus, and tensor fasciae latae, while the underactive muscles could be the glute max, anterior tibialis, hamstring complex, and the erector spinae. The final view, which is the posterior view, compensations to look for are feet flattening or heel rise. As before mentioned, it was a little harder to do, being my client did not want to remove her shoes. In the lumbopelvic hip complex, we are looking for weight shift. I noticed again in this view that there was the feet eversion, the weight shift, the dumping, which became more obvious at this lower left arrow, and again there is anterior lean. This corresponds with the previously stated overactive and underactive muscles. Next, we have the single leg squat, which is a movement that assesses dynamic movement, core strength, flexibility, balance, and neuromuscular control. In the anterior view, we are looking for valgus in the knee and hip rotation, hip hike, as well as hip drop. I noticed in my client on both knees that there was valgus. You can see it immediately here, and followed by the right knee, or the left knee. The overactive muscles would be the adductor complex, the bicep femoris, the gastrocnemius, soleus, TFL, and vastus lateralis. The underactive muscles are the anterior tibialis, glute max, glute med, hamstrings, posterior tibialis, and the vastus medialis. There's also weight shift in the lumbopelvic hip complex, which could relate to an overactive adductor complex and tensor fasciae latae on the squatting side, as well as an underactive core stabilizers and gluteus medius, while the non-squatting side would be expected to have a tight or overactive bicep femoris, gastrocnemius, and piriformis. And on the underactive side, the adductor complex would be underactive. It is noticeable in this view that she drops her chest, which will be touched on in the next view. As before mentioned, you will notice knee valgus and weight shift on the legs. As before mentioned, there is slight dropping of her chest, which can relate back to the overhead squat assessment, which pointed out that the overactive muscles would be the adductor complex, external obliques, gastrocnemius, psoas, rectus abdominis, rectus femoris, soleus, and tensor fasciae latae. And the underactive muscles, as before, would be the gluteus maximus, anterior tibialis, hamstrings, and the erector spinae. Next, we have the dorsiflexion test. This measures the ankle's ability to dorsiflex. In this view, we are looking to see if the client has the ability to touch the wall with their knee or has any compensations in the foot, such as heel lift, any sort of rotation, or valgus. This is on the right leg. She can touch it, the wall, with her knee. And this was performed for 2 repetitions. Following, you will see on the left leg that she was able to touch the wall again. Now you would have noticed in both views that there was absolutely no heel lift or anything of the sorts. While in the posterior view, you will notice that her right foot slightly elevates here. It's not much, but it's just enough. And when I was watching the footage back, I just assumed that it could have just been a bad rep, being that on the left side it was fine. I also noticed on the right side that she had a slight hip drop. Now this again could account for it just being a bad rep. She did about 5 or 6 takes of this, and she could have just began to get tired in those muscles. Now we have the modified Thomas test. We are testing for extension and abduction of the hips as well as knee flexion. Here we will test the knee that is hanging off the table. We're looking at the lumbopelvic hip complex and looking for hip abduction. We are also looking for the compensation in the lumbopelvic hip complex and knee. We are looking for the upper leg to elevate off the table or abduct away from the torso. We also want to see if the knee is not at 90 degrees. It is noticeable in the left leg that when she elevates her right leg and pulls it in towards her, her leg begins to lift by the lumbopelvic hip complex, indicating a tight rectus femoris, meaning the overactive muscles are the iliopsoas, the TFL, sartorius, and obviously the rectus femoris. The underactive muscle would be the gluteus maximus, hamstring complex, and core stabilizers. Her right leg does not appear to have any issues in this anterior view, as will be noted here. Next up, in the lateral view, again, her right leg does not seem to have any issues, but her left leg does raise again indicating the tight rectus femoris. It's noticeable here by these arrows and these circles. The next test we have is the Davies test. This is from the anterior view. This test is done by having the client tap hand to hand quickly but controlled. Generally, this is done for 3 sets of 15 seconds. Unfortunately, due to time constraints, which was the gym telling me I had to leave due to the time, I was only able to get a very bare bones Davies test. We are looking for the trunk to remain stable with a neutral spine and stable scapula. We are also looking for anterior head carry and making sure that the scapula does not wing. In both the anterior and lateral view, I noticed that my client has excessive posterior tilt in her lumbopelvic hip complex, which is noticeable here in this circle. And when I begin to play it, you will notice that she slightly elevates her hips. The overactive muscles would be the hip flexor complex, i.e. the iliopsoas, rectus femoris, and TFL, as well as the erector spinae, latissimus dorsi, and for underactive, it would be the gluteus maximus, hamstrings, and core stabilizers. Now, as I mentioned before, you can also see this in the lateral view. Slight posterior tilt. And as we mentioned before, the overactive muscles would be the hip flexor complex, the erector spinae and latissimus dorsi, and the underactive muscles would be the glute maximus, hamstrings, and core stabilizers. For the final assessment, we have gait, which is the assessment of posture while walking. In the anterior view, we are looking for compensations in the feet, knees, and lumbopelvic hip complex. For the feet, we want to see if there is flattening or outwards turning. In the knees, we want to see if there was a inward motion, such as knee valgus. And in the lumbopelvic hip complex, we are looking for asymmetry and weight shift. Now, in the anterior view, you will notice that my client begins a catwalk or tandem gait, and this would mean that her overactive muscles could be the adductor complex, TFL, hip flexor complex, bicep femoris, gastrocnemius, and soleus. Peroneals, posterior tibialis, and latissimus dorsi could also be overactive. The underactive muscles would be the glute medius and maximus, intrinsic core stabilizers, anterior tibialis, vastus medialis obliques, and serratus anterior. Her reasoning for doing this is more than likely being that she competes in bikini bodybuilding, which requires her to walk almost like a model. She practices this walk very often, and it may have in turn hurt her normal walking mechanics. Playing this one more time, you will notice that she pushes off the outside of her foot when she walks. The overactive muscles for this could be the posterior tibialis, soleus, gastrocnemius, bicep femoris, glute max, and hip external rotators. The underactive muscles could be the peroneus longus, the brevis, the VMO, the glute medius, and the adductors. Now next, in the lateral view, we are again looking for weight shift in the lumbopelvic hip complex. Now we are also looking at the shoulders and arms to see if they are restricted in any way. The compensation that I noticed would be the restricted arm movement as well as the before mentioned push-off. In the restricted arm movement, overactive muscles would be the pectoralis majors and minor, the latissimus dorsi, the upper trapezius muscles, the levator scap, the teres major, and the subscapula. The underactive muscles would be the middle traps, lower traps, rhomboids, posterior deltoids, rotator cuff muscles, and serratus anterior. Finally, we have the posterior view, and we are looking for excessive pelvic rotation and if the feet flatten or turn out. Here I saw what I noticed in the anterior view, which was the catwalk and the push-off of the feet. And as before mentioned, for the catwalk or tandem gait, the overactive muscles would be the adductor complex, TFL, hip flexor complex, bicep femoris, gastrocnemius and soleus, peroneals, posterior tibialis, and latissimus dorsi. And then the underactive muscles would be the glute medius and maximus, intrinsic core stabilizers, anterior tibialis, vastus medialis, oblique, and serratus anterior. And then back with the foot, the pushing off the outside of the foot, the overactive muscles could be the posterior tibialis, soleus, gastrocnemius, bicep femoris, glute max, and hip external rotators. And then the underactive muscles could be the peroneus longus, brevis, VMO, glute medius, and the adductors. Thank you.